everyone. Welcome to the International Interprofessional Mentorship Program. I am Dr. Kate Barlow, the founder of the program and your host for today's meeting. It's November 4th, 2020, and today Dr. Allison Sullivan is here to talk about treating substance abuse. Please mute yourselves during the presentation and unmute yourself whenever you would like to ask a question. You can also type your questions into the chat box and I will ask the questions for you. In order to receive a certificate of attendance, please enter your name and email into the chat box now, and you will need to remain on the webinar until the presenter is finished. At the conclusion of the presentation, we will have an optional meet and greet. Thank you all for coming today, and let's get started. Thank you, Dr. Sullivan, for coming.
Thank you, Dr. Barlow. I'm going to share my screen, okay?
Yep.
Great. Okay, so let's get started. I'm going to be talking to you tonight about behavioral health intervention strategies and continuing professional development for occupational therapy practitioners. Just a little bit about me before we get into our topic. I am the faculty lead for our post-professional occupational therapy doctorate here in Springfield at American International College. My teaching responsibilities include scholarship of teaching and learning in occupational therapy, OT theory, and courses involving psychosocial aspects of the development of occupations, group dynamics, and occupational therapy mental health practice. My research interests include the pedagogy of psychosocial occupational therapy education, attitudes towards people with intellectual disabilities, trauma-informed care, and movement-based therapies for mental health-related disorders. When I'm not actually teaching, I've been working as an occupational therapist since 1994. Currently, I work as a clinician for Cushing's Programs for Families and Children in Northampton, Massachusetts. I work as a staff occupational therapist for a residential school serving children from 8 to 22 with significant social emotional learning needs. In my background, I have worked for quite some time at Sunshine Village in Chicopee, Massachusetts, where I was a staff occupational therapist for a rehabilitation program for adults with developmental disabilities. And prior to that, before entering education full-time, I worked as a school-based occupational therapist where I served in a variety of roles. I had my own business for a while. I was a contractor and supervisor for OT, PT, and speech therapy services, working in over 20 different school systems in Massachusetts over that period of time as a staff OT, as a supervisor, and as a business owner. My other occupations include I'm a board member of the Allen Cognitive Group. I serve on the Human Rights Committee for Viability, Inc., which is a rehabilitation program for adults with intellectual disabilities. I serve as a board member on the Lighthouse, which is a psychosocial clubhouse. I've been an AFA certified group exercise instructor for over 30 years. I'm a yoga instructor, an avid gardener, and what I consider to be a humble cook. And I am a mother, a wife, and a dog lover as well. So if you hear some barking in the background, that is my I call him the heartbeat at my feet, Tito. So my first goal tonight is to help you understand the relationship between an experiment I conducted recently with my students in which I had them participate in an innovative computer simulation training in screening and brief intervention referral to treatment, otherwise known as SBIRT, and their confidence, preparedness, and accuracy of the participants in selecting appropriate responses when using this skill in a virtual assessment. So I want to talk to you a little bit about what's going on with the patient's occupational therapy and occupational therapy practitioners encounter. Here in the US, substance abuse is a tremendous problem. 19.4% or 53.2 million people from 12 years of age and up have used an illicit drug in the past year, and over 7% meet the criteria for substance use disorder. That is 20.3 million people, and that's from SAMHSA's latest national survey on drug use and health in 2018. So one problem facing occupational therapy these days is that most OTs who do not work in behavioral health settings do not seek out professional development in this area of practice. And this is a big problem. How can we ensure occupational therapy practitioners' competence in mental health skills and knowledge, regardless of practice setting, if they don't seek this out on their own? We are supposed to be client-centered. If we don't understand our patients' behavioral health needs, how exactly are we client-centered? So when we start thinking then about how people come about getting skillful and understanding their own needs with regard to professional development related to behavioral health, we come right up immediately against problems with traditional educational methods. When we start thinking about the basics, the fundamentals of behavioral health intervention, we need to immediately think about skills that all OTs have to address: screening, assessment, and evaluation and referral. These aspects of care involve specific communication and interviewing techniques, and traditionally, practice in one-to-one live role rehearsal is the standard teaching method. However, research shows that feasibility and effectiveness is questionable using this one-to-one live role rehearsal methodology. Clinicians themselves do not possess motivational interviewing expertise. And when we start talking about behavioral health, we need to understand that motivational interviewing is an evidence-based approach that maximizes the chances of moving people with ambivalence about approaching change into a position where they will be more open to receiving intervention to help them with these issues. Occupational therapy practitioners who don't work in behavioral health are really uncomfortable initiating conversations about this topic with their patients. And of course, we always come up with time constraints as well. Everybody's working against productivity. So computer simulation training really presents an efficient, cost-effective means for increasing practitioners' competency in techniques commonly used in psychosocial OT in low-risk learning activities. Computer simulation training has been identified as a promising instructional methodology for promoting health education, learning, and skills development, and learners experiment with a range of behavioral health intervention techniques more when using computer simulation than in live role rehearsal. So this is, I think, a really important point to make, in that when I talked with other OT educators around the country about how they were actually establishing competency with their students in these skills, most of them said there was some sort of, they might bring in actors, or they might have some student-to-student intervention activity planned. And because of that, students are not going to experiment, learners are not going to experiment, and you can imagine that clinicians are not going to experiment on their patients. So the nice thing about computer sim is that there is no one who is going to receive a negative impact from having someone try a technique where they say to themselves, I know this isn't the right way to do it, but I'm not sure why. I wonder what will happen if I try this. So computer sim is great because it lets you try things that you might not be able to try other ways, and really establish in an experiential way for yourself why the best route works in the way it does, and why less successful avenues work in the way that they might if you didn't know that otherwise. So Cognito is a company out of New York City that specializes in this type of training. And they they have a variety of simulations that you can use in order to prepare you for developing your skills in a variety of behavioral health intervention settings. So you can see here, this is their screening and brief intervention with adolescent skills training. And there were 3 clinical cases. And in this particular sim, what they have happen is that you play the role of the clinician, and you get 2 cases in which you're guided by a coach through an intervention session where you have screening results, you talk to your client, you select from a number of choices about how to proceed with the interview. The coach can prompt you to make better choices or ask you about what's the next step and guide you to best case scenario answers. And then you do a final case study on your own that allows you to get what's considered a challenge score. The goal is to receive a score of 75 out of 100 in each of the competency areas that's being assessed. And so what is screening, brief intervention, and referral to treatment? This is SAMHSA's evidence-based practice for identifying, reducing, and preventing problematic use, abuse, and dependence on alcohol and illicit drugs. Why should we be interested in SBIRT? SBIRT works. Screening and brief intervention was the single most effective treatment method of the more than 40 treatment approaches that SAMHSA studied, particularly among groups of people not actively seeking treatment. And for those of you who may not know, SAMHSA is the Substance Abuse and Mental Health Services Administration organization for the US. So it is our clearinghouse of all evidence-based practice related to substance abuse and mental health services. So in the experiment that I ran, I used this SBI skills assessment approach, and I had the students go through these 2 practice scenarios with different virtual human beings in various settings. And there, if you can purchase this individually online as well, and you will get an understanding specifically of an objective score of your abilities with regard to engaging with the interview participant, building rapport, eliciting pros and cons of making behavioral changes, providing feedback to the subject, assessing clients' readiness to change, negotiating a plan for action, summarizing and thanking, and your motivational style. So this was extremely successful training with my students. I looked at 2 different areas of competency: students' self-perceived preparedness, as well as their confidence in 4 different domains of intervention. 1, screening using valid instruments. 2, conducting a behavioral health conversation. 3, using motivational interviewing. And for those of you who don't know, motivational interviewing is the treatment intervention technique that is the basis for SBIRT. So motivational interviewing takes people from a position of neutrality in their interviewing style and helps clinicians use a more proactive approach to helping address client ambivalence. And when we talk about ambivalence, we don't think about people not feeling any way. We think about people being extremely torn between very strong emotions, pulling them in different directions. I know I need to get treatment, but I also know that if I do, I could lose my job, I could lose custody of my children. What's going to happen to my insurance? This is going to be expensive. And so motivational interviewing recognizes that Committing to treatment is a difficult decision that most people will be torn when coming to that conclusion, and helps clinicians use language that helps move people towards change and towards positive action. And from motivational interviewing is where SBIRT was developed. So that's the third component. And the final component is following up or referring for additional care. So you can see that upon taking a pre-test before engaging in the training, lots of yellow and white, right? Very little green. My students did not feel prepared to do any of this. After engaging in the training, however, you can see lots of green. People felt much more prepared to screen using valid instruments. They felt very much that they were ready to conduct a behavioral health conversation with their clients. They felt much more prepared to use motivational interviewing, and also the vast majority felt much more comfortable about understanding where to follow up or refer after intervening in this way. So this is students without a lot of experience in the clinic. So you can imagine that clinicians taking part in this training, I would imagine that you would see even much more significant changes. That was the preparedness. And in terms of confidence as well, you can see a huge change in those same domains of intervention. Students felt much more confident in their ability to screen someone using valid instruments, conduct a behavioral health conversation, use motivational interviewing, and follow up or refer for additional treatment. So understanding then that we can and should be using computer simulation training to improve our clinicians' competence and confidence in our behavioral health communication and intervention skills. I also want you to understand that why is this important? We need to be able to strengthen our understanding of the core values of our profession and demonstrate leadership across practice settings, and in using these skills so that we can be complete professionals. How, again, can we really claim the mantle of being client-centered if in our various treatment settings, we're constantly skirting the issue of clients' behavioral health? When I followed up with my students, there was very nice clinical evidence that they valued the training. 100% of the 44 students who completed this survey agreed that the simulation was based on scenarios that are relevant to their work with patients. 98% rated the simulations from good to excellent, and 93% stated that they would recommend this training to their peers. In terms of the qualitative follow-up, students provided me with feedback that, again, was striking. I liked how the responses created a real-life response and experience. I was particularly attracted to this following student comment. There were a few instances in which I selected the wrong response, and I really appreciated how the program explains why mistakes are incorrect. That helped me learn a lot about the appropriate way to phrase feedback in order to avoid language that may lead the individual to consider reasons why they cannot achieve their goals. And another student commented, "This will be very helpful, and I definitely plan on utilizing this knowledge." So I really do believe that most people, most occupational therapists, are not adverse to having a conversation about behavioral health with their clients. They just don't know where to start, and they don't feel confident that they can do it well or do it the right way. And this type of computer simulation can really provide people with the confidence to move forward in addressing these issues no matter where they work. So we can develop leadership in SBIRT programs. In the US, there are actually separate CPT billing codes that if you establish an SBIRT program in a place where it doesn't exist and you contribute to it, you can bill out on those codes. So there's a way to be reimbursed that could create a new revenue stream for your business. But as I mentioned earlier, in order for us to be able to develop and lead these kinds of programs, we must first possess the ability to deliver these skills competently and have sufficient confidence and preparedness when doing so to use and promote SBIRT effectively. So, in moving away from this, I'd like you to think about this idea. If we're able to instill in all OT practitioners the significance of developing competency and accuracy in using appropriate techniques when discussing and educating clients on their substance use, we better prepare all OTs for leadership. Failing to adopt training such as this within OT practice almost guarantees that supervisors will have less objective and validated tools for developing employee skills in this area. What are you doing in place of this? And how do you give people objective feedback in those specific areas? This really represents a risk factor for poor quality interventions and outcomes for people with problematic substance use who receive OT treatment. If you're working in a skilled nursing facility or in a rehab, and somebody is there because they've injured themselves in a fall down the staircase, and you don't know that that fall was caused by that person being really not aware of how their alcohol was interacting with their medication, and you rehab them and send them back home to their old habits without ever discussing this with them, you're really setting them up for failure. So I wanted to provide you with some opportunities to use and practice with these skills. So I just wanted to show you Cognito's resources for this. And hopefully I can open that up for you. Is that opening? Doesn't seem like it is. How about this one? It's not opening. All right, I will open it up for us. All right, this is not working so well tonight. Sorry about that. No, that's not it. Here we are.
I was going to say, I just pulled it up on mine if you want me to pull it up.
Oh, no, I got it. So, okay, so you can see, and I was wondering from the participants who are here tonight, Here is one. So there's 4 free different sims for you to look at. This is called Building Family Bonds, a virtual home visit, playing the role of a family support provider. Learn to coach a single parent how to read with your son, or primary care visit on antibiotics. I really like this. There's 2 different perspectives. One is the physician talking to a virtual patient, and the patient is trying to get antibiotics, and the physician is not eager to provide them. And in the other one, you get to be the patient, and you would like to get antibiotics, and you're going to try and talk about the physician, to talk to the physician about why you feel those antibiotics will help you. And the 4th sim is Calm Parents, Healthy Children, playing the role of the parent. Learn to manage the behavior of your 2 to 5-year-old child during common stressful situations. So is there a sim that you prefer? Dr. Barlow or any of our participants tonight have a preference?
Go with the building family bond.
Building the family bonds, sure. It just takes a minute to load.
Hi, I'm Barbara. As a family support provider, I know that one of the most important goals of a home visit is to give parents the skills and the motivation to use what you teach them, even when you're not there. For example, it can be hard to convince struggling parents to read with their children. They may have little time, higher priorities, or bad school memories of their own. To change their view of reading, parents must believe that reading will benefit not only their child's long-term future, but their own day-to-day lives. And they must understand how to engage their child at his or her own developmental level. So, what techniques are the most useful for building skills and motivation in parents? To answer this question, Cognito, with support from the Robert Wood Johnson Foundation, has designed this simulated conversation between a virtual family support provider and a single mom. In this simulation, you'll play the role of Sarah and decide what to say to Christina and her 2.5-year-old son, Oliver. Sarah has worked with Christina for a few months, and together they recently set the goal for Christina to read to Oliver 3 times a week. But without a good understanding of what to expect when reading with a toddler, Christina has been quick to get frustrated. As Sarah, your goal is to coach Christina in how to read with her son in a way that will work for her. To do this, you must first build a good rapport with Christina. Then, you'll use coaching methods to model the technique for Christina while she observes you and check in to make sure she understands what she's seen. Invite her to practice the techniques herself. Debrief to ask about her thoughts and answer her questions. Plan a goal of specific ways for her to work reading into her day. And plan a time to follow up with her. To talk with Christina, you'll choose what to say from a menu of choices. How well the conversation goes will depend on the choices you make. I'll coach you through this visit, letting you know the effectiveness of the tactics you're using. Unlike real life, if you regret any choice you've made, you can always pick undo to try a different tactic. When you're done, we'll talk about how the conversation went and what might be most effective in a real visit. Are you ready? Let's begin.
So how have you been feeling the past few weeks?
Fine, I guess. Just tired, you know.
How's the morning sickness?
No more puking.
Well, that's an improvement. And how's Oliver? Last time you said you wanted to read with him more? 3 times a week, right?
Yeah, I mean, I tried it, but he was awful. It was awful. I don't think he's ready for reading.
So what do you want to do? Get information, empathize, or encourage? You guys tell me. Dr. Barlow?
Emphasize.
Emphasize? Empathize. Okay.
Oh no, that sounds really frustrating.
It was. I was ready to start crying right along with him.
Yeah, it can be tough when you're trying to do something fun for your kids and they just won't cooperate.
I know, it's like, why am I doing this at all? I turned off the TV and he just started screaming and ripped up the book you gave us.
Okay, so talk options are to give info or get info, make a comparison, or make a suggestion. Anybody have a suggestion for me?
Make suggestion.
Make suggestion.
For a child Oliver's age, TV can be a lot to take in. He might just need a little more time. Maybe a heads up before it goes off and a chance to make a better transition into the next thing you're going to do.
I don't have time. By the time I get home from work, I just want to collapse.
The transition doesn't need to be long, just letting him know that you'll start to read when the show ends. It'll give you time to get comfy.
I know. I should have given him more time.
Mama!
Hold on a sec, Ollie. Mama's talking now. Sorry, it all seems like a lot of work.
So your options are undo, and then see down here now the coach is offering comments. Transitions are tough for a lot of kids. It's normalized. It's normal. It's great to normalize for parents that a quick transition can be the reason behind their kids' meltdown. And then, so you can undo that if you want, or you can give information or get more information. You can paraphrase, reflect back what was said to you. You can provide encouragement, or you can make a comparison. What do you guys want to do next? See, the nice thing when you're doing this kind of simulation on your own, you can try each one of these answers just so that you know. You don't, there's no all or nothing. What are you most interested in seeing in the short time that we have?
Try paraphrase.
It sounds like you feel like reading with Oliver might make more work for you.
Well, yeah, let's just add it to the list.
I know, you have a lot on your plate. Work and Oliver and getting ready for the baby.
Exactly. I mean, I barely have time to use the bathroom.
You really got to the bottom of Christina's trouble with reading. She agrees in theory that she'd like to read to Oliver, but she still thinks of it as another task to be accomplished, kind of like learning about behavioral health in different practice settings. As long as she sees it as work, not a fun bonding time with her son, she will be less likely to follow through. So I hope you're getting the sense of how this works. And in the PowerPoint, I've created for our work together this evening. The links are right here. And I can also show you Cognito's demos briefly. And you can just see the full range of really wonderful products. So those 4 SIMs that I showed you are complete SIMs. They were developed for the CDC with a grant from the Robert Wood Foundation, and they're free and complete. So you will actually be able to do the entire SIM. You'll get feedback on how you did. You'll have as many opportunities as you want to try to improve it. And I think that that's a really wonderful benefit of being able to try this technique for learning. It suits many different purposes. But you can see there's 24 different simulations: at risk for early childhood, elementary, faculty and staff, mental health for students, middle school, high school, behavioral health, bullying and prevention. There is this more elaborate parents, healthy kids, chronic disease management, families of heroes, that is specific for working with military families, a friend-to-friend SIM, and interpersonal and therapeutic communication skills, patient and caregiver education, pediatric care, resilience, sexual misconduct, working with LGBTQ youth, telehealth, military again, and trauma-informed care for different populations. So I've been so impressed with these products. I'm not paid to represent them. I just found that the simulations seem very natural and lifelike to me, and the benefits that my students received from practicing with them was significant. And I felt that they got a lot more information about their interviewing skills than I could ever personally give them myself if I was trying to do that. So beyond Cognito, I wanted to show you some other resources. So SAMHSA, the Substance Abuse and Mental Health Services Administration, has a whole video training site from what they call their Brass Tacks Technical Assistance Center. You can access video trainings that promote recovery-oriented services and supports that highlight new knowledge areas, hot topics, and cutting-edge programs. I use motivational interviewing for peer support providers with my students as a setup for this training in screening and brief interventions. It's a wonderful overview of the primary features of motivational interviewing. I've included the link to the recorded webinar, as well as the separate link for the PDF to the slides themselves. So you can view it with the recording, or you can just view the webinar slides yourself. But I've found that that's a great way to introduce motivational interviewing. And I've often thought of the benefit of and the value of providing peer support, clinician training, because frequently we do wind up caring for others that are not necessarily our patients. Other resources from SAMHSA, I included the link to the SAMHSA store. I don't know if people are aware, but SAMHSA store has so many evidence-based resources for individuals with a whole host of different mental health conditions, substance abuse, and other evidence-based treatment areas. And almost all of the items in the store, I think people don't realize, are free if you download them electronically. To purchase manuals or hard copy, there is a cost associated with that, but you can download as many copies as you want free electronically. And along with that is their evidence-based resource center. You can locate evidence-based interventions for any kind of diagnosis, mental health diagnosis, age group setting, other specific population interests. If you just interested in looking up gender-specific evidence-based interventions or population-specific interventions, the filter helps you locate that. Beyond SAMHSA, I'm going to escape so I can show you this other website, Get Self-Help. Get Self-Help is a terrific website if you're not familiar with it. So many different resources. Again, almost all of it, there's so much of it is free. And so many different kinds of downloads and MP3s. I encourage my students to use it as well. There's just wonderful, all different kinds of ways to think about anger, for example, if you wanted to see worksheets. Every different kind of issue that you might want to have some sort of documentation system to go back and forth. There is spiritual orientation for some of the materials as well, which I thought is really helpful. I really like the STOP. I don't know if you're familiar with STOP method, right? STOP is CBT, and stop, take a breath, observe, pull back, practice. And they have apps that you can use, and they have worksheets that you can use. It's a wonderful, wonderful service to the world, all in one website. There's a whole DBT side to this as well, if that's an interest that you have. I would like to point out that one of Dr. Barlow and my co-faculty, Christine Helfrich, has some wonderful manualized resources. If you contact Dr. Helfrich at AIC, I'm sure she would give you permission to access the manuals for free. And she is an expert in public health as well as occupational therapy. And these manualized interventions were part of the National Institute of Health grant. And it's a group manualized interventions for life skills. There's one manual for food management, one for money management, home care, and self-care. I also, and safe community participation. And I think I do have an example of the manuals, and maybe if we have time, I can take that out for you. And I also included Betty Ford, Butler Center for Addiction Research here. I didn't want to limit people to just SAMHSA and my co-faculty. And I think they have some wonderful free resources there as well, if you're interested in improving what they're offering there. I also included some screening tools. I included the following screening tools in this presentation. The audit is alcohol use disorders identification test. The audit is a 10-item screening tool developed by the WHO to assess alcohol consumption, drinking behaviors, and alcohol-related problems. There's both a clinician-administered version and a self-report version of the audit, and the link is there, and as well as a website with regard to scoring and interpreting the audit. So the audit has 10 questions, and possible responses to each question are scored 0, 1, 2, 3, or 4, with the exceptions of questions 9 and 10, which have possible responses of 0, 2, and 4. So the range of possible scores is from 0 to 40, where 0 indicates an abstainer who's never had a problem at all with alcohol, and scores of 1 to 7 suggest low risk consumption by the WHO guidelines. 8 to 14 suggest hazardous or harmful consumption, and a score of 15 or more indicates the likelihood of alcohol dependence. Excuse me. I included a link to the CRAFT as well. The CRAFT is a very efficient and effective health screening tool designed to identify substance use and substance-related risk driving and substance use disorder among youth aged 12 to 21. CRAFT stands for the 6 items in the second section of the assessment, which is car, relax, alone, forget, friends, and trouble. There's 2 versions of the CRAFT. There's a clinician interview and a self-administered questionnaire. Research has shown that adolescents report greater comfort and are a higher likelihood of honesty with self-administered questionnaires. There's electronic versions that are available or paper when compared to face-to-face interviews. The self-administered version is also more time efficient to administer than the interview itself. And for that reason, the authors of the CRAFT recommend the self-administered version in most cases. The CRAFT plus N versions contain extra questions that are related to tobacco and nicotine use. And those are also available as a clinician and a self-administered questionnaire. So what are the implications for practice from all of this? I would like to, if I can be so bold as to quote myself from my Age Odd article in 2017, given the complexity of promoting safe, effective, client-centered, sustainable health outcomes for people with disabilities, health professionals must continue to develop opportunities and adapt practices that maximize learning in our clients and in ourselves. And there's my contact information. And now I'd be happy to take your questions. No questions, huh? I know it's a lot, right? Is there anything
Thank you so much, Dr. Sullivan. And if people have questions later, is it okay if they email you and ask their questions if they think of them later?
Absolutely.
Okay, great. This had so many good resources. Thank you so much.
You're welcome. Enjoy.
All right.
My pleasure.